Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're glad you joined us this morning. Before we begin, I'd like to thank our sponsor, Altman Health Systems. Today, Brad and I are broadcasting from the administrative offices, and our very special guest is Dr. Zachary Stender, a board-certified orthopedic surgeon. Good morning, doctor, and welcome to the show.
Good morning, and thank you for having me.
Dr. Stender is with OrthoUnited, a newly formed joint practice between Spectrum Orthopaedics and Omni Orthopaedics. Dr. Stender is a board-certified orthopedic surgeon with expertise in sports medicine, specifically with knee and shoulder. We'd like to remind our listeners that our program is also available on our podcast. Just look for Health Matters with the Medicine Center Pharmacy in your favorite podcast app, and please subscribe to our program.
So good morning again, doctor. Tell us a little bit about yourself.
So my name is Zachary Stender, and as you said, I'm a board-certified orthopedic surgeon. I specialize in sports medicine. I actually grew up and I was born and raised in Chicago, and I went away for college at the University of Wisconsin. Believe it or not, I was an accounting major there and didn't get interested in medicine until a little bit later, but kind of working in an area that I wasn't really interested in really, focused me to find something that really was my passion. I went to medical school at the Chicago Medical School in Chicago, and then I got an orthopedic residency at the University of Connecticut. I thought that, during residency, my passion was sports medicine, and I did a fellowship at the Detroit Medical Center where we took care of the Red Wings, the Pistons, and the Tigers. And then I came back to Chicago and practiced for 5 years and moved here. And I'm in my 5th year of practice here in Ohio.
Wow. So being a sports medicine surgeon, you see patients with knee issues. Let's start with meniscus repairs. Tell us the signs that there's a meniscus tear and what are the causes?
So there are a couple different causes of meniscus tears that I see very commonly. And I would just break them into 2 broad categories. There is one that's a traumatic tear, that you were walking around and you had no knee pain before, and maybe you twisted funny, or you could be playing sports and you twisted funny, and then all of a sudden you have sharp pain on one of the sides of your knee and sometimes and often swelling. So you were doing fine before, you had some specific incident, and now you have sharp pain on the side of your knee with or without swelling. So that's the first kind. The second kind is maybe your knee's been aching for a while, and slowly over time you develop pain that increases in severity on one or both sides of your knee. So those are kind of the main signs that you have a meniscus tear, regardless of how it happened, are sharp pains, mostly when you twist or turn on one of the sides or both of the sides of your knee.
So this can just be wear and tear on the knee. Is that also true as opposed to damage, football, baseball, I don't know, whatever,
Correct. Meniscus tears do not discriminate. They can get young football players, they can get weekend warriors, and they can get people who are, just walking around and gardening.
Tell our listeners what the meniscus is.
So the meniscus is,
go ahead.
The meniscus is a cushion, basically. So you have your femur bone and your tibia bone that make up the bones of the knee joint. And then those bones are lined with cartilage, which is basically a frictionless surface that provides some cushion and shock absorption for the knee. And the meniscus, you have one on the inside of your knee called the medial aspect, and one on the outside of your knee called the lateral aspect. And it provides like a shock absorber for the knee. And in addition, it's a secondary, provides some stabilization for the knee.
I don't know why nature couldn't have just put a hinge there. It really is complex, I guess, isn't it? When you think about what forms everything around it. Interesting. What is there a non-surgical remedy to damage or just torn?
So that's a great question. In my practice, I am always looking for a non-surgical solution if I believe that that treatment is going to be just as good as the surgical solution. So I would say in a 16-year-old football player that, was previously completely healthy, twisted, turned, felt a pop, had swelling, and has just a meniscus tear, I would say in that case, there's really very little role for conservative management. And that patient is pretty much taken to surgery almost all the time, pending some very specific circumstances. In a patient who's kind of developed the pain over time, and I call that more of a degenerative meniscus tear, there are lots of non-operative treatments, and they span from just ice, rest, activity modification. Sometimes a simple brace can prevent the knee from twisting in that funny position. And sometimes a cortisone injection is used in the office. In addition, we use some physical therapy to strengthen the muscles around the knee that can provide some additional stability. And it's also important to know that, if you take an MRI of 100 people over 50 years old, a high percent have a meniscus tear, and it may not bother you. So just because you have one doesn't mean it needs surgery or even really any intervention.
So we don't necessarily have to operate to repair a meniscus, correct?
That is correct.
Okay. Can it fix itself?
So the way that I best think it's easy to understand is the meniscus doesn't really fix itself. But if you imagine the meniscus as this shock absorber, and if you get a tear in it, sometimes in this shock absorber, you can get a leaf of the tissue or a section of it that kind of tears and is sitting in the wrong position like a hangnail. And like a hangnail, it's very irritating. But sometimes that tear is laying completely flat and really doesn't get in the way. And sometimes it may bother you intermittently, but sometimes it can flip in the wrong position or it can get stuck somewhere and doesn't lay flat. And that's where it can cause you the most symptoms.
So, okay, we got a torn meniscus. Are we limping, or does your knee buckle, or occasionally, or am I going the wrong way here? Or?
No, you're going the right way, and I wish that I could make it completely simple, but there are different types of meniscus tears, and some of them where the meniscus is completely torn all the way through in the back of the knee, that can actually result in a feeling of instability. So the meniscus is a secondary stabilizer of the knee. The main stabilizers are your ACL, your PCL, your medial and lateral. You have some collateral ligaments that provide some stability to the knee. But the meniscus is a secondary stabilizer. So if it's completely torn, you can have a feeling of instability. But generally, in most cases, the meniscus is not providing stability, but it provides the shock absorption. It also provides some nutrients and fluid for the knee. And I would say that it runs the gamut. Some people who have this meniscus tear can be limping around, and some people can be walking completely normally, not even knowing that they have a meniscus tear.
Very interesting.
So I'm thinking about your descriptions of, surgery is necessary to maybe you could put it off. And it makes me think of patients that come in the pharmacy and maybe they know they need a knee replacement or they need to have some type of surgery and they do everything they can to put it off as long as they can. I guess I'm wondering if you could maybe paint a picture for the listener for, okay, you have a meniscus tear or you have an issue where you need knee surgery. Can you help give them an idea of what that looks like and what they would experience to build some confidence that it may not be as bad as they picture in their mind of what they're going to go through? And I only say that because I had one of your colleagues, Dr. Shepard, he repaired an ACL for me about a decade ago. And it was one of those things that I was never really afraid of, but it was an amazing experience to be to go through that from the standpoint of being injured and then realizing what it takes to have surgery and recover. And it really wasn't that intimidating of an experience. It took some work and PT and all that. But, I guess I want to see if you can help build confidence for our listeners, because it is one of those things that I feel that, you guys at your team do an amazing job. And I think that they should have confidence in the process and be comfortable with what could be possible.
So I think first and foremost, should you decide to have surgery? So one of the reasons I got into sports medicine specifically is the part of orthopedics I liked the most is because I think it's one of the areas of orthopedics where people have some of the most exciting outcomes, like the best outcomes. Usually, people are coming to me because they had some injury or their knee hurts or their shoulder hurts and they can't do things that they want to do, or it's disrupting sleep. And, maybe we run the gamut of non-operative treatment, and eventually, if those things have not worked and we get to surgery, the surgeries that we do are really, 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 first, technologically advanced, and overall very successful at getting people back to the things that they want to do. So I think that can build confidence, is that really in almost every circumstance, I'm able to get, my patients back to the level of activity that they were doing before. So I think that can build confidence. I think that another way to build confidence is I always make available resources to my patients to be able to read about the surgery in addition to what I tell them. And also there's other patients out there who've had similar procedures that I think that really helps and provides a support network to just kind of help, especially, you talk to somebody who's been through this same thing. For example, Brad, somebody maybe who've torn their ACL, if they came to you, you could tell them, hey, I was nervous in the beginning. I didn't know what I was getting into, but I got fabulous care. It wasn't as bad as I thought. There was a lot of rehab, but I ended up all right and I'm doing well now. So I think that all those things can, instill a lot of confidence.
Interesting. Okay, Doctor, our first break is here. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. Friends, just a reminder to stop by the pharmacy and talk to our pharmacist about our Health Matters drug savings program. We want you to help you stay well and save money.
Okay, doctor. So we were talking a little bit about non-surgical options before the commercial break, and so surgery is necessary. What does prepping for surgery look like? And can you touch on what arthroscopic surgery means for a listener who may have to have a procedure?
Okay, so starting with arthroscopic surgery first, I think that's a good place to start. So arthroscopic means that we are doing it through very small, tiny incisions, and we are doing all of the work with basically a arthroscope, which is a camera, and then arthroscopic instruments, which are designed to perform minimally invasive surgery. So you can do arthroscopic surgery of all kinds of different joints. I specialize in the knee and the shoulder. And the wonders about it are that it's outpatient surgery. You are going to come into the surgery center in the morning. You're going to get taken care of by our wonderful staff. You're going to meet our anesthesiologists we only use the best anesthesiologists around. You will have your procedure and you will go home that exact same day. So in terms of preparing for the surgery, it's really pretty simple. All of the information really and questions are answered in the office. In addition, I always provide information published by the American Academy of Orthopaedic Surgery on, whatever specific injury you've had and the procedure for you to review. The day of surgery, we review all questions that you may have if you haven't had a chance to ask them yet. And at that point, really the only thing you need to do is not have anything to eat or drink before midnight, and the rest kind of taken care of. If you do have any special medical considerations, we are teammates with the primary care physicians and cardiologists in the area. And we don't take you to surgery unless, it's as safe as we could possibly make it. And if you've had to meet with your primary care physician or cardiologist and be optimized before surgery, we always take all of those measures.
So how does a minimally invasive surgery like you're describing impact recovery time and discomfort?
So I can't promise that it helps with discomfort because we can really do so many incredible things through these small little poke holes. But in terms of healing and incision and infection rates, it's made a tremendous difference in those areas. It's still, even with minimally invasive surgery, so important that you follow the post-operative instructions and do all the physical therapy and rehab that's associated with it. But it's surprising, but with these small instruments in the camera, for example, if you were to take a rotator cuff tear or even an ACL or a meniscus, you can actually see more around the joint using these special instruments than you could if you were making a big incision.
Gosh.
That's pretty interesting. What kind of so you mentioned physical therapy. What's a garden variety case for a patient? What would they expect for recovery time and physical therapy?
So this is something that I see all the time. So say that you work in a factory and you're on your feet all day long. So you have a meniscus tear, you end up having surgery. We're trimming out a portion of the torn meniscus. We're not fixing it at this point. You'll have your surgery, and even though you'll walk out of the surgery center, and you're walking right away, about the average time. So what we do is I provide everyone with a home exercise program for 2 weeks. And you do that home exercise program, ice, and kind of work through things on your own for those 2 weeks. And then we have our first 2-week post-op appointment. And I ask you how you're doing. And about 90% of people at that point are doing really well with their home exercise program. Some people need a little bit of a push and a little extra help. And that's when we start physical therapy. If you had a meniscus repair, you start physical therapy right away. That being the difference. I just think that when you don't repair the meniscus, you can do a lot of it on your own. And sometimes it's easier, especially if it was your driving leg that we operated on, to not have to drive places and get somewhere, while you're recovering. It's easier to do the home exercises at home. So going back to the factory worker who's had meniscus surgery, I would say that even though you're walking right away, to be able to do a job in which you are standing, maybe carrying things back and forth all day, the average time to get back to that is about 6 weeks to 3 months. People have gone back much sooner than that. People have gone back a little later, but that's about the average. If you work an office job, as soon as you're off the narcotics, which can be 2-3 days after surgery, you can go back to work.
Amazing.
Okay. So, Dr. Stender, another knee issue we all seem to hear a lot about is a torn ACL. Can you explain what an ACL is and how it may get injured?
So an ACL is one of the important stabilizers of the knee. So you don't really need it for just walking or running in straight lines, but if you are cutting, pivoting, turning, it provides stability for the knee. And the typical way it gets injured, there's 2 ways. It can get injured, and you hear what's called a non-contact injury when you see somebody running on the football field or the soccer field, and they just go down. Like they make some cut, their leg doesn't go with them like it should. It maybe gets stuck in the turf. They hear a pop, there's immediate swelling. That's one way. The other way is a traumatic way where it gets, hit. Something bangs into your knee, a person or your knee runs into an object. And the consistent theme is that generally you feel a pop and there's immediate swelling in your knee. And generally when it happens, it's not that the ACL tear is painful, but because your knee shifts when it happens, it actually causes bone bruising, and that can be painful. And so I would say an indication that you have an ACL tear is feel a pop, have swelling. That's the take-home message.
Jeez. So what is the difference between a minor tear and a full tear, and how does the next step of treatment differ from these?
So for the most part, there can be some degeneration of the ACL over time. But the way that I treat it is the ACL is either functional or not functional. And so I don't really look at partial tear versus complete tear. It doesn't really matter to me. If it's functioning and you have a stable knee, we call it not torn or sprained maybe. And if it's not functional and your knee is unstable, that's a complete tear. Whether or not there could be a few fibers of the ACL still intact, I look at functional versus not functional. And then taking it from there, there's 3 types of people who have ACL tears. And it's really about a third, equally distributed. 1/3 of people need their ACL fixed no matter what. 1/3 of people can kind of cope with it, maybe wear a brace. And 1/3 of people don't need it fixed at all.
Okay. Why don't they need it fixed at all?
So I'm not sure that we completely understand exactly who those people are. But for example, Hines Ward played in the NFL.
I gotta break into you. It's time for the news.
Okay.
Hold that thought, okay?
Sure.
All right. Our second break is here. I'm sorry to cut into you. Welcome back to Health Matters. This morning we are talking with Dr. Stender of OrthoUnited. Sorry to interrupt you, doctor. Please finish.
So we were talking about that some people really don't need their ACL. And it's not exactly understood why, but the best example is Hines Ward, who was a wide receiver for the Pittsburgh Steelers for years, had no ACL, and he functioned at quite a high level. So I don't think we know exactly why, but there's certain people that just don't need it.
That's wild.
It becomes useless? Is
It's not useless. I think that his body and some people's bodies like compensate with, different muscles, different bony architecture. I think that it's not exactly figured out yet.
Interesting. Okay. So tell us about ACL surgery, and is it more complicated than meniscus surgery?
So I wouldn't say it's more complicated. It's different. It is, instead of either trimming out, a partially torn meniscus or repairing a tear in a meniscus, this is you're providing reconstruction of a ligament that's torn or not functional. And so the recovery is different. And an ACL isn't always an injury that's isolated. A lot of times it can be associated with the meniscus tear. So you may be recovering from both. And there's there's several different types of grafts, but the 3 main ones that we use, divided into 2 categories, are we use category 1, that is your own tissue. And that way we can use quadriceps tendon, patellar tendon, or hamstring tendons for your own graft, or you can use allograft, which is cadaver tissue. And both can be used for ACL. The allograft can be used in an older patient population that's less demanding and do very, very well, and you have a little bit less to recover from. But I think that in patients who are pretty much 30 years, 25 to 30 years and younger, I think all the studies have shown that you have a much higher success rate with your own tissue.
Interesting.
All right. Well, I guess I'm the recovery guy question again. And since I had some experience with ACL, can you tell our listeners, and maybe I can share some of my experience too, if you don't mind, on what recovery time looks like for ACL and what you can expect from the procedure?
So the ACL, unlike the, meniscus surgery, this is always physical therapy. And there is a home program associated with, but it is always complemented with physical therapy. And it takes about 3 to 4 months for that graft to be completely incorporated. And it takes anywhere from 6 months to a year, plus or minus, for you to build up all the strength and all the secondary stabilizers in your knee again to be able to function at the highest level. So if you tear your ACL and you have it reconstructed to get back to work at a sitting job or even a standing job, that can be 6 weeks to 3 months. But if you are trying to play high school football, that can be a year. It can be as little as 6 months, but it can be up to a year and sometimes even longer. But this is a no compromise on the physical therapy. Your success is definitely directly related to the effort that you put into your surgery. And what I always say, especially with an ACL, is really 30% of it is me. Like, I will do a good job putting things in the right place, but 70% is the work that you put into it afterwards. Brad, I'm interested to hear what your thoughts are, having had this done.
I would agree with that. It was interesting. I mean, I think that, my surgeon did an excellent job, Dr. Shepard there. And I was, I'm not used to being a patient. As a pharmacist, we're used to helping patients find a solution for their therapy. So it was interesting because I injured mine playing soccer. And it was one of those things where, like you described, I heard the pop. And when I heard that, they had to help me off the field because I probably had that swelling and I was, kind of stunned or whatever and couldn't walk initially, but I was able to walk home and tell my wife that I think I have a problem. But after surgery, it was interesting. I think my experience was I had a lot of muscle wasting like in the first week or so. And I was really surprised how much strength you lose when you don't use those muscles. So I think it was extremely important and very obvious that I needed to do physical therapy. I did, I think 2 full cycles of it because I wanted to play soccer again and was able to get back to doing that. But it was humbling in a way to be reminded that, how strong your good leg is and how weak your bad leg is. And so I do totally agree that, don't, for the listener, don't discount physical therapy. It doesn't have to be scary. It doesn't have to be painful. But the reality is it's going to help you be more confident in what you do on a daily basis, whether you're playing a sport or just walking around or climbing stairs. And I think it really makes all the difference. So I was really pleased with my experience, and I don't want to do it again, but at least I understand that, you get exactly out of it what you put into it.
Yeah. And so it's a fantastic answer. And you can see how earlier we were talking about in the conversation, ways you can prepare for your surgery and, what kinds of things you should be doing before surgery. And talking to somebody who's had this surgery can make it seem a lot less scary. And it really helps when you can see somebody who's gone through it successfully. And it gives you an idea of what, the end and the goals look like when you're stuck in the what's happening now situation.
Yeah. Okay. So let's talk about shoulders and rotator cuffs. We hear a lot about that in the pharmacy too, where people did something and they just heard a pop. So let's talk about rotator cuffs. How common are those and what is that experience like?
So rotator cuffs, like the knee, two main types. There is the type that develops over time, and there's the traumatic type where either you fell, you bumped your shoulder, you were pulling the starter on your weed whacker, and those are immediate pain and weakness. And I'd say that the 2 most commonalities between the 2 of somebody who's just developed shoulder pain over time and somebody who's had a traumatic injury is weakness. And I would say that if there's one thing that gets people into my office more than anything else is not the pain, not the weakness, but if it's disrupting people's sleep, that's what brings them to my office. So it's disrupting your sleep, then it's time to do something. Of course, there are indications to do surgery before that, but when it disrupts your sleep, that means the tear has kind of reached a critical size, and it's, you can't underestimate the importance of sleep towards, functioning during the day.
So what kind of tests do you do to determine if you have a torn rotator cuff?
So there are tests of strength in the office. Like people can see us right now.
Yes.
So one main test that I do is you can have your arm held out in front of you and a little bit out away from your body, and you hold it up like this. And if it's weak compared to the other side, that's a good indicator that you have a rotator cuff tear. And of course, if you can't raise your arm at all, that's a indication that you have even a bigger rotator cuff tear.
Gee.
Right.
Okay.
But people who have rotator cuff tears tend to most commonly have pain with reaching above their head. And like I said, they feel weak. And when they know it's time to do something with, maybe they should have been in before, but what brings people in more often than not is it's disrupting my sleep. And if they don't bring themselves in, their partner who's sharing a bed with them brings them in. I see that a lot.
Wow. Okay. So tell us about the different ways a repair can happen, and what is your preferred procedure at OrthoUnited?
So, kind of rotator cuff repair has taken three kind of main iterations. They used to initially make a big incision, take the deltoid muscle, which is a big muscle around the shoulder, off, so you could see some of it, repair the rotator cuff with an open technique, and then close everything back up again. So you were healing not only the rotator cuff, but you were also healing the removal of the muscle and the skin incision. And then we figured out a way to do it without taking the muscle off, which is just a smaller incision. But now the way I do it, and I believe is the best way to do it, is all arthroscopic, which is minimally invasive. And this is kind of what I was explaining before. Because of the bony architecture of the shoulder, with these arthroscopic instruments, you can see and do so much more than, believe it or not, you could within a big incision. You can just see all around the shoulder. And so the way that I repaired is arthroscopically. And there's all kinds of different tears, but the general gist of it is you're putting a bunch of stitches that are these Kevlar strength stitches into the torn rotator cuff, and then you anchor it back down to bone using, a number of different types of anchors. You don't have to heal any incision, but you are in a sling for 6 to 8 weeks. We're really, depending on the exact post-operative protocol and the size of the tear, really you're just working on passive range of motion, which means that somebody is helping you or using a pulley system to move your shoulder, and you really don't start doing it yourself for 3 months. And it's about a 6-month recovery for a rotator cuff to get back to work.
Okay, doctor, our final break is here. You're listening to Health Matters with the Medicine Center Pharmacy.
You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Welcome back to Health Matters with the Medicine Center Pharmacy. I am your pharmacist, Paul White. Pharmacist Brad White, and I thank you for joining us. Let's get back to the last segment of the show. What does the patient do to prepare for surgery, and then what is the time frame for the actual surgery?
So this depends again on the type of injury. So
Sure.
In the traumatic injury where somebody was ripping the cord on their weed whacker, felt immediate pain, and
Is that something common that happens?
Yeah, well, I just had that patient.
Did you? Oh my gosh.
You can fall into your shoulder. You can be lifting something heavy, and you feel a pop, and you have pain and weakness. Come into my office. I know right away on exam that we're dealing with probably a larger size rotator cuff tear that's traumatic. We get an MRI, which confirms it. And in this specific situation, we tend to do surgery sooner because I think that all the evidence that we have so far shows that for these acute traumatic tears that happen with an injury, if you fix them sooner, they do better. Otherwise, you run the risk of it getting to be a bigger size tear and potentially not repairable. So people do better with surgery sooner. So for this specific incidence, now that we've had the MRI and confirmed it, even from the first visit, I set you up with a specific set of home exercises just to keep your range of motion, because I think it's really important that, you know, we don't create a second problem of stiffness when you don't want to use your arm because it hurts. So I'm not trying to torture you, but it is important that we work on, you know, keeping your motion so you don't get stiff. We take you. Same thing with the knee. It's outpatient surgery in our surgery center. You're in and out in a couple of hours. For this one, you're in a sling for 6 to 8 weeks. We start physical therapy at 2 weeks after surgery, and somebody will help start moving your arm for you and show you ways to do this at home. And then at about 3 months, we start, you know, you moving your arm yourself and starting to build strength. And it really is about a 6-month process to get back to work. And it can be 8 months if you have a bigger size tear. But I'd say for these traumatic tears, 6 months as long as 8 months. And then for the tear that's kind of been, you know, just lingering and in the background and now is bothering you, affecting sleep, we don't have an emergent time frame for this, but it's more when it's convenient for you and your schedule, and we find a time together that we can just do it.
What if I'm a baseball pitcher? How soon can I get back?
Right, so that is a different animal. The throwing shoulder is a different animal, and I would say that for a baseball pitcher, throwing the baseball doesn't necessarily usually result in a rotator cuff full tear, but they get wear over time, and they get more problems with the tendons around their shoulder, like the biceps tendon. And so you have to, the throwing shoulder is a very unique thing that relies on flexibility, and you have to be very careful on what you're fixing and not fixing in a throwing shoulder so that you're not compromising that patient's flexibility that allows them to throw the way that they do. So different topic is the throwing shoulder, but equally important, and just kind of has some different considerations when deciding what to fix and what not to fix.
Well, it's interesting that there's a couple of those pitchers out there over the years that have lasted forever, clear into the 50s, you know, and they're still pitching, which is kind of amazing that a shoulder can hold together, you know, that long, or an elbow or whatever. So what are these guys made out of anyway? Rocks or what? The one pitcher I can remember, the one in Texas, shoot, I can't remember his name. But
Nolan Ryan?
Yeah, Nolan Ryan. He lasted in the 50s, as I recall.
Yeah, he was up there. But interesting. So when I was with the Detroit Tigers, they had Max Scherzer and Justin Verlander.
Yeah.
On that team at the same time.
Yeah.
And those guys have been an incredible testament to keeping your bodies in shape and hard to really pitch, you know, late in their careers at a highest level.
Yeah. Amazing.
So in the spirit of that, do you have any tips for injury prevention for athletes or weekend warriors? I mean, what can you recommend based on what you've seen?
So the one thing that I see with my high school athletes, with my weekend warriors, with anybody, is it is so important to warm up and stretch before you do your sport or work out, and even cool down afterwards. I think that's the one thing that I see that is universal, is we don't see enough flexibility work and warm-up work before people play sports. I think that's the biggest thing that you can do. And then I'd say the other biggest piece of advice, especially if you are a weekend warrior, is if you haven't, I'm just taking tennis, for example. If you haven't played tennis in 3 years, it's really not a good idea to get yourself involved in competitive set playing tennis. You know, if you haven't done it in 3 years, go warm up, hit the ball for a couple weeks, then get into it. I think that if people kind of looked at that, there'd be a lot of injury prevention. But if we had one take home message, warm up, stretch, stay flexible. I think that prevents a lot just in itself.
Interesting.
All right. Well, I think it'd be a good time for you to leave your contact information, doctor, and how patients or listeners can get in touch with you if they have questions or they need to come visit you to get evaluated.
So we are at the corner of Frank and Apple Grove. OrthoUnited is 2 campuses, the Omni campus and the Spectrum campus. I am with the Spectrum campus. Our telephone number is 330-305-0838. And we're available. Come see us. If you are having any kind of issue that is affecting your quality of life, you can't do something you want to do, something's bothering you, we'll get you right in. We have world-class doctors who really care about their patients using state-of-the-art instruments and techniques to get you back to what you want to do. And so any issue, we can handle it. We have, again, world-class doctors taking care of our local patients. Come see us.
Well, okay. It's time for final words, Doctor. What do you hope our listeners hear and take away from today's show?
I think that, if you're taking away anything, I think I said, if you're playing sports, warm up, stay flexible. But, we all know that these things aren't always possible. And I think that the take-home message is don't suffer. If you're having an issue, we can help you. Come in and see us, OrthoUnited. We'll get you in right away. We won't make you wait. And like I said, world-class doctors taking care of our local patients.
How many doctors are in the organization now?
I think we have just under 40.
Gosh, that's amazing.
Yeah, and we cover basically every orthopedic specialty. So
Wow.
there really is anything that we can't handle.
Wow. Okay. Thank you to our guest, Dr. Zachary Stender with OrthoUnited. If you suspect you have a medical issue, please contact your healthcare provider. Thanks to Altman Health Systems and listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week. We'll see you right here again next Friday on News Talk 1480 WHBC. Thank you very much, Doctor. Very interesting. Take care.
Thank you very
much for having me. It's been a pleasure.
Yes, sir. Have a good day.
Have a good day.